One.
Hey everyone, Dr. Thomas O'Connor here. Excited for this live event. We have to open up with, hold on guys, let me just set up. There we go. Thank you so much, Mark. All right, everyone, I'm really excited for tonight. Welcome to this live event. First, I'm going to give a presentation on hypertension and the etiology, the causes, and the mechanism of action of hypertension related to testosterone and androgens, steroids. And then I'm going to talk about what you can do about that. From my Mark, can we put me up? How do I? Yeah. Okay. Let's keep it right there. Guys, we're live, so this is how it goes. So got a whole great team here. .com/live. And is that what it is, guys? Is that what that is? Put that up, Mark. Can you toggle that on so people can see that? Want you guys to come on board with me to have questions. I'd like to see some of you guys. Otherwise, you can just type your questions in and no one's going to see who you are. But let me just... Steve, can you make sure that Mark shows these things? Mark, please show the announcements of how to get on stage. All right, guys, hypertension. Hypertension is one of the most important modifiable risk factors for preventing strokes, heart attacks, kidney disease. You see, I just go from the top down. Heart failure, peripheral vascular disease, erectile dysfunction. It's no joke, guys. I think I could get you guys on, do you want to never have a stroke? Do you really want to prevent what's called vascular dementia? So up to 50% of dementia, it's not Alzheimer's disease. That's superimposed on top of vascular dementia. I want you to fact check this stuff. And if you look for vascular dementia, it's very simple. The ABCs. A1C, glycemic index, diabetes and prediabetes, blood pressure, B, and C is the cardiac stuff, including abnormalities in cholesterol. I'm not going to say hypercholesterolemia anymore because I know it irritates people, even though it's complicated. Thank you, Mark. So you guys want to get on stage, testosteronology.com/stage, and then just, there's no membership, there's nothing. You just have to click on some stuff to get on stage with me here. So get ready for that, guys. Back to the hypertension talk. Hypertension, diabetes in the beginning, and dyslipidemia, which means abnormalities in cholesterol, for which there are several. These are all 100% silent, 100% silent when you're young. However, there's damage occurring to your heart and to your kidneys and your erections, men. This doesn't happen in your 20s typically, right? You see this stuff in your... The heart disease actually starts with the lipid and the dyslipidemia and the glycemic indexes on your genetics and hypertension and all this stuff. Of course, smoking and drinking and drugs and stress and all this. But you start to get early deposits of heart disease, and that's plaque, right? So that's a multifactorial complex scenario. Hypertension is one of the really big ones. But I think hypertension is even more important because hypertension is so silent, and depending on who you are, what group and who you are in America, age, socioeconomic and status is, if you will, and so on and so forth. Some people have 70% hypertension and they're not treated. You can check that. So hypertension is where your body needs to pump blood. So there's a pump. There needs to be a specific pressure, and that's the blood pressure we check in the arms, right? So, and you want to get a great blood pressure monitored at home. You really don't need to get monitored in a doctor's office anymore, but I don't want to stop you from going to a doctor or a good healthcare practitioner. No. But the truth is what that blood pressure is in that office, that moment, is that how important is that versus how's your blood pressure 24/7? So how do you capture that? You can do an ambulatory blood pressure monitor where you wear the cuff for 24 hours, and every hour in the hour it goes on and off, right? And it measures, and that's kind of academic, right? And you can do that. That's an ambulatory blood pressure. I used to do those for my patients when I really wanted to see their blood pressures. But you know what I do now? I just get them a blood pressure. I get them to do blood pressure logs at home in the morning and at night. And if you can during the day. So for about 1 week, you want to check your blood pressures. And again, I want to give all this is evidence-based supported information from journal articles and really good conservative doctors over the years and years and years, right to today. So this is the standard of care today. So what's your blood pressure? Now, if you have hypertension, right? So if you're hypertensive, now what is that? 120 over 80 is level 1, not because of the 120. That's pre-hypertension, right? But they don't call it that anymore. 80 is level 1 hypertension. And you can fact check that. And you're going to go, wow, what does that mean? Well, it means that if you're lower than 80 and 120 over, if you're like 119, 118 on the top, and if you're 79 or 78 or lower, don't want to go too low. This is the trick, right? Especially when you're using medicines, it's not easy to do. That's why I'm here to help you guys with all this information. When you bring it down and you hold it that low versus someone who's not that low, over the course of time, we see that the pathology, again, for the stroke, for the vascular dementia, the heart, the kidney, the erections, you start to see it. There's an area under the curve and there's a differential. And when the blood pressure is not optimal, you really end up getting disease. And it's a slippery slope. It's so, when you're older and you feel like you're not that intelligent and your memory is off and these things, that's vascular dementia. Okay, so I can't hammer the stuff enough, right? So what are the mechanisms of how testosterone and steroids cause hypertension? Let me tell you how this works, because we know this and we've known this for years. So when you take exogenous androgens, now there's a dose-dependent phenomenon. If you take a little bit of testosterone, even that could cause hypertension, depending on who you are and these facts. But the more you take, there's absolutely going to be a dose-dependent phenomenon. The more you take, the worse it get, the worse it's going to get. So there's no rocket science on that. So let's understand, for an example, a guy who's taking testosterone, either a young guy, middle age, or an old guy, he's taking testosterone a little bit, a lot bit, and he's hypertensive. What's the mechanism? And then again, so that's starting off with TRT, even a little TRT, especially the injections, guys, but we do love it. If you look at this, you're going to be a little puffy and bloated potentially. And inside your arteries, there's intravascular edema, right? That's the hydraulic pressure, voila. And that's hypertension. So how does this system set up where the blood pressure goes up when you're taking testosterone, especially the injections? But it can be pellets, it can be gel, the nasal gel, it could be the oral, and they all have a black box. All these medications, testosterone, they do have a black box warning for hypertension. They remove the cardiovascular warning, but they put a new one on for hypertension. And for all you guys who I want to fact check that, you're going to fact check it. You could buy me a coffee, I guess. I don't know. It's just, this is not bullshit. It's true. Here are the mechanisms of action for TRT and steroids, how they cause hypertension. It's a multiple overlapping mechanism of action. Always in my world, it's multifactorial. That's the tough thing about this. It's never just one thing. It involves the kidney, the vasculature, the autonomic nervous system, erythropoiesis. That's the thick blood stuff, right? Cardiac remodeling. There is a highly effective, dose-dependent, highly individualized, amplified by polypharmacy, sleep apnea, obesity, stimulants, salt intake, insulin resistance, and genetic predisposition. Let's keep going on. So, number one, let's go into the most obvious from a nephrologic. As I'm an internist, right? So, the kidney. The kidney is there to do amazing things for you. The kidney is there to maintain electrolytes. It's a filter, and it does amazing other things with erythropoietin, helping the body to make red blood cells, and it manages and maintains blood pressure. Woo! Now, how does that work? The kidney system has something called the renin angiotensin aldosterone system activation system. It's RAS, RAAS, renin angiotensin aldosterone. And this mechanism we know in internal medicine, this is nephrology, with steroids and even a little testosterone. Here's what happens. The aldosterone is affected and increased, which relates to sodium retention, water retention. Aha. So you see the puffiness in the face on the steroid users, maybe the ankles are puffy, and of the intravascular volume goes up. This is a hydraulic pump. Endothelial dysfunction, myocardial fibrosis. Look, you're hypertensive now mainly because of the perturbation on the kidney system with the RAS system. Number one. Next, we have direct vasoconstrictive and vascular tone effects. We also know that anabolic steroids and testosterone directly on the endothelial vasculature, which is throughout your whole body, but the arterial side, right? And especially the classic medial arterioles, the mean arterial mass, which controls your blood pressure. They are going to be under steroids. Definitely things like Tren and different strong drugs. Steroids, they cause a vasoconstrictive effect. What happens when you put your finger over the end of the hose, the pressure to squirt your buddy? That's just it's a Laplace law. It's just a physics, hemodynamic law of physics. So when that surface area comes down in that region, in that diameter, when the flow and everything else is the same from the pump that pumped it, the pressure at that region goes up. And then the whole system with the wave goes up, and that's damaging pressure back up on the wall. Strokes, heart attacks, vascular dementia, kidney disease, erectile dysfunction. Okay. So next, those are direct vasoconstrictive and vascular effects. And we could also go into increased endothelin. One, this is all for you really good bro science guys out there. Maybe some doctors are listening. Reduced nitric oxide bioavailability. Go to Google, put in, does hypertension cause erectile dysfunction? And you're going to see some interesting things. We've known this for years. It's called the canary in the coal mine. They put a poor canary in the coal mine, smell. He's going to go in there and smell. There's no smell, carbon monoxide. And if he doesn't come out, the coal miners don't go in. Okay, so it's silent. Okay, this is silent disease. So canary in the coal mine, silent erectile dysfunction is a harbinger of coronary artery disease. We've known this for decades. So, and what happens when men have non-optimal blood pressure when they're young and getting middle-aged? Erectile dysfunction. There's your nitric oxide, and there's your PD5 inhibitors, Viagra and Cialis. They work directly on nitric oxide. Let's keep going. Increased vascular stiffness. That's just atherosclerosis in a summary, where when your A1C is bad, you're glycemic and you're diabetic, you're getting older, you can't do anything about age except age gracefully, right? And try to be humble and try to minimize all these adverse mitigative effects across your body. But however, as we get older, we have atherosclerotic disease across all the blood vessels. They stiffen up. And again, like the finger at the end of the hose, when you stiffen up the pipe, when it has a hydraulic flow, the inside of the pressure, the pipe itself is not elastic. When you're young, it's very elastic. So it absorbs the pressure, and therefore the pressure in the system stays the same. When the pipe is tight and it's hard and stiffened, it can't go anywhere. So the pressure in the system this is the danger. Again, this is all stuff everyone knows. Good doctors know this. Sympathetic nervous system activation. Steroids increase adrenergic tone, catecholamine, heart rate. This is, doc, I'm on testosterone. My heart rate's going up. Boom, boom. Again, that's not hypertension effects. That's a autonomic vascular effect. The blood pressure and the heart rate are hand in hand with cardiac output. Next, sodium and water retention. I'm going to hit it again. That's the RAS effect. This is something that's clinically so relevant that when you're on testosterone, your blood pressure goes up. The first thing you have to do is really be vigilant on your sodium. The DASH diet, DA, go to Google. Best diet for hypertension, capital D, capital A, S, H, DASH. It's a more of a plant-based Mediterranean diet, and it's low salt. Don't believe any of these goofy guys that are young and steroids, and they're saying you need sodium. It's an absolute embarrassment, because of course you need sodium. We get way too much sodium, and I don't add salt. Well, you're still getting double, the triple, maybe 400% the amount of sodium that you should be taking, and you should prioritize potassium-rich diets. Let's keep going. I'm hoping you guys are liking this. We're almost done. Kidney effects, direct renal mechanisms, testosterone itself and steroids on a dose-dependent variable cause glomerular hyperfiltration. That means that the steroid is affecting the renal tubules and affecting that function of the heart, the heart and kidney, it's all I do, of the kidney itself, the nephron. And what happens is you start to get something called remodeling and hyperfiltration. Again, the response to that is the kidney's not doing well. And then the response is with the RAS system, the blood pressure goes up when you have chronic kidney disease. When you start getting in the beginning of that, and then as chronic kidney disease goes through, and if you're in this world of kidney disease like I am in internal medicine towards dialysis, we know that patients' blood pressure goes through literally the roof. They literally go through the roof because their kidneys are not able to maintain blood pressure anymore. So that's number 5. Again, the tubular sodium handling chronic kidney disease amplifies this. So many of you are going to have chronic kidney disease with proteinuria, and you don't even know it. You can get on the Testosteronology Health Portal. You can get your own labs with no doctor's prescription. And you could literally ask questions, and I could determine this. And my testosteronologist, we could find this stuff early on you. It's very, very true. You can get your labs, no doctor's prescription. You could understand on the health portal all the metrics. You have your own ABCD portal, your own dashboard, where you put it in. I've spent my whole resources, so many resources. I don't want to be a drama guy. Spent a lot of resources on this, guys, for you. But it's all there for you. It's there that I've scaled the whole thing. And then, of course, here I am to help. Let's keep going. Erythrocytosis, polycythemia. In my feeling, I've had arguments with endocrinology experts, hypertension experts, hematology experts on how much does the erythrocytosis, the thickened blood, does it cause hypertension? There's controversy on that, but I'm going to give way, and I'm adding it here. Imagine I didn't add this. Oh, I got him. He didn't add that. It's really most men when they're young, even middle-aged, the erythrocytotic effects, right? That's my D, the androgen-induced erythrocytosis with the iron deposition, that's the D, or the depletion. When you're dumping all this blood and you're making everything worse and you're losing your iron and you feel terrible, and it's just that you're just in this conundrum of this vicious cycle where you're constantly dumping blood, and it's just horrible. And what are you doing it for? There's no data to say that you should be at this metric of hemoglobin less than 17 grams per deciliter. It's all completely wrong. It's just wrong. It's individualized for your risks for venous thromboembolism. That's DVT and strokes. And that's what these guys are all thinking, but there's no direct line from A to B it doesn't work that way. But I'm telling you that what some men on testosterone that have a significant effect from the increased red blood cells called androgen-induced erythrocytosis, this is my day job, that's the D, and that it can lead to headaches and blurry vision, and they can be hypertensive. Okay, but it's unusual, and it's because the body has a lot of support. The body doesn't break overnight, right? So the body has a lot of alternative feedback and a lot of absorption ability, if you will. It doesn't happen that way for some people, though. My hemoglobin now is 17.4, and my blood pressure is going up, and I feel kind of my little headache, and I phlebotomize and I feel better. Okay, that's unusual. Okay, it's usually the erythrocytotic effects. Even hemoglobins north of 20 grams per deciliter, they don't feel anything. Okay, but hemodynamic consequences, that's the viscosity that we talked about. Again, it's controversial, but you have to understand it. Then the last is once you're hypertensive on androgen, you get this, it's remodeling. It's very dangerous. And there's an increased afterload. Once you start remodeling with a myocardial, this is where the heart and the kidneys they work together. And this is my world, right? Cardiology, nephrology. This is internal medicine. So when you start getting left ventricular hypertrophy, concentric remodeling, diastolic dysfunction, which is heart failure with preserved ejection fraction. I am not kidding you. There's not just heart failure with reduced ejection fraction. I want you to check this. There's something this is not new, by the way. There's something called heart failure with preserved ejection fraction. It's still heart failure. And it's not that easy, even for me, to diagnose it. The criteria is quite tricky. That's why when you're hypertensive, you really want to get an echocardiogram, right? This is all in the app. It's all in our health portal. Let's keep going. Steroids, estrogen. Aha! I know you guys are waiting for that. You take testosterone, you aromatize, you get estrogen. There's no question the estrogen makes you puffy, and it does lead to hypertension. The estrogenicity of testosterone is going to be multifactorial, dose-dependent, steroid-dependent, man-dependent, fat-dependent, salt-dependent. And then again, this is this mechanism of testosterone or the estrogen. It's just follow the trail. It comes from testosterone. So testosterone and estrogen, the way the PhD experts that are doing all the animal studies on this stuff, they've been doing it for years. I know a lot of these guys. It's mammal study, right? Because we're mammals, right? So they juice up all these rats and monkeys. It's kind of sad. More rats, I guess, than monkeys. And they used to do it to dogs. So mammals, right? And I love animals. So it kind of breaks my heart. And I'm not really for this, but we have to progress science. It's not easy. And it's a tough thing. But when you look at the models on this, we know that testosterone and aromatization, and depending on how much and so many variables and so many receptors that people have, it can lead to different downstream effects of hypertension. It's some people do, some people, again, there's a lot of variability. So, but that estrogen related. Now, how about this? When women are childbearing age, and they have, listen to this, when they're going through their menstrual cycle, right? Estrogen, progestin, all that, it's up and down. Now, when their estrogen is spiking, are they hypertensive? No, they're not. Young women, you see? There's a lot going on here, guys. So is it just estrogen mediated? No. But if it's you and you're taking too much testosterone, if you're at one of these clinics and they're giving you 200 milligrams of testosterone every week, broken down into 2 injections, and the AI and all this kind of stuff, and the clomiphene and the N-clomiphene and the HCG and gonadorelin and gonal-F and all the peptides. Again, I'm just having fun with you guys. Good for you. What's your blood pressure? It's the cheapest thing. It costs nothing to do it yourself. Fluid retention, estrogen related mechanisms, fluid dynamics. I had to get it in there. Sleep apnea amplification. So if you have problems with circadian sleep, if you're a cop and you have to work first shift, third shift, back to the second, fourth, right? If you have to do fourth shift, some guy was telling me about the fourth shift. What the hell is the fourth shift? That's when you work overtime. I was like, that's crazy, sir. It's terrible. So anyone who works the circadian rhythm, it's terrible for sleep related issues for hypertension. So that's just on top of the testosterone. Body composition, obviously if you're overweight, it's going to get worse for blood pressure. Super physiologic testosterone and steroids are going to be much worse. So in the end, to wrap up, ready for questions. So the supported mechanisms for the data for how hypertension relates and secondary to steroids and testosterone is renin, angiotensin, aldosterone system, kidney, sodium water retention, endothelial dysfunction directly on the inner wrapping of the artery, sympathetic activation in your body's just activated nervous system, erythrocytosis, hyperviscosity, direct renal, and then vascular stiffness and cardiac remodeling. Done. If that's something good for you guys, let's get some questions in now. I hope you guys have fun with that stuff. I was wondering if you could tell me what's the best book on endocrinology in regards to testosterone. Best book on testosterone. We're kind of beyond books right now. So if what we really are, there's a lot of books on testosterone back in the 1990s and maybe turn of the century. When I was in med school and residency training, there's a steroid book called Anabolics, the 11th edition. You might want to look at that. There you go. Check out Anabolics. Awesome, dude. That's so weird that I said that and you came up. So Bill Llewellyn, which includes chapters. Thank you so much. I wrote some chapters. Guidance physiology. Awesome. Thank you so much, sir, for supporting me on that. Victor Serrano, my doctor, Victor Serrano. Ooh, awesome. So again, those are the books. But if you really want to know about testosteronology, come here. And if you're a doctor or a healthcare practitioner, join the Testosteronology Society. Tonight is mainly for the members and for non-healthcare practitioners, but become a certified testosteronologist. So we have 57 under training. We have 26, including me, on the World Directory. You can check that. Go to Testosteronology Health Portal, testosteronology.com, and go to find a provider. You can be one of them. But I can tell you right now, those are the chosen. It's been over 2 years. And I tell you, we have grand rounds meetings. We make guidelines. I have Omar Hajmosa, who's my Pharm PhD, my PharmD expert, who's a whippersnapper, 28-year-old guy who's super smart, who's a professional pharmacologist in a hospital, children's hospital, and he's working for us. So let's get some more questions, guys. More questions. What do we have here? Any questions? And if you want to take a question, you can step up to the stage. I want to see someone on here. So I have to ask, how high can natural bodybuilder get without tier steroids? That's the age-old question, John Wismer. Dude, so you can go so far naturally, but let's be honest. Unfortunately, so many people, we used to train back in the day. I'm 62 this year, right? So we used to train. I got up to about just under 240. And about 5'10", 240. And I was puffy, and not from steroids, just tons of food. I was, 5,000 calories. I just wanted to be big and strong. I had the body dysmorphia, which I still have to some degree today. And I started doing my first steroids, unfortunately, 22, 23, on and off. Within a few years, I had to be on testosterone the rest of my life. It worked. I had the devil here, do the steroids, the angel, don't do them. Oh my, and that's just what it was. And when I was around back in the 80s into the 90s, it was just a different thing. It was what age did I start? 22. And I'm going to go like this for you guys. I mean, I'm 60. I'm a 62-year-old guy. I'm lucky to be alive, man. I had heart disease in my 30s. You guys know that. I think if you follow me, and you can see that I've stabilized some of that and actually cleared out some of my own heart disease. But again, look how aggressive I am with my ABCs, right? Very aggressive. And I've been on super complex, biotechnology, PCSK9s, a little bit of a statin. Guys, don't hate on statins. And I've kept my blood pressure. My blood pressure has been perfect, probably only for about 10 or 15 years. I'm honest, even before that, I just was, whatever. I would take a little lisinopril. Blood pressure might have been 140 over 90 for years. Me, and around 50, again, I'm 62, around 45 to 47, I started to really, again, I was the anabolic doc for 10 years already. And I was taking care of patients in my arms that were dying in dialysis, heart disease, kidney disease, suicides. I mean, I'm a drama guy because that's my business. Guys come too late. Next question. Let's keep giving some more questions. I want to see one of you guys come up here if you have some real questions. Best way to control hematocrit well on TRT, 50% becomes normal. Okay, there's nothing wrong with 50%. So best way to control hematocrit while on TRT. Okay, let's talk about hematocrit. Let's talk about, this is my D. This ABCDs. This stands for, the D stands for iron deposition or deplete. So A is A1C, B is blood pressure, C is cholesterol and cardiac. I had to come up with a D for the red blood cell stuff. And how do you do it? Well, it's called androgen-induced erythrocytosis or polycythemia. I don't like polycythemia because polycythemia stands for polycythemia vera, which is a malignancy, and it's just you're paying Peter to get Paul. It doesn't. You're borrowing from Peter to pay Paul. It doesn't make sense to me from a hematological. It's wrong. It's just wrong. So I said, let's make up what it really is. Let's tell it as it is. Androgens cause increase in red blood cell production. That's called erythrocytosis. Is it too much? I don't know. That's your problem. It also affects the iron status. Too much or too little. That's ferritin and iron. And you can get when you're looking at the hematocrit, that's the CBC. Did you know that steroids, testosterone, there's only three things on CBC. There's the white blood cell line, there's the red blood cell line, and platelet line. That's it. And then on a differential, all the stuff on the bottom is just broken out, the white blood cell differential. Neutrophils, eosinophils, basophils. Come on, guys. This is just in my blood since the 1990s. I mean, so when you look at testosterone, it only affects the red blood cell line, never affects the WBC line, never. When I say never, imagine I'm saying never, never. Now, it's very rare that it affects the platelet line, very rare. And that's a very esoteric, I could talk about that with ITP and idiopathic thrombocytopenia. Imagine I'm going to go into that. I can't do this. So anyone who says it affects the platelets, that's cringy and embarrassing. It's an embarrassment. It just is. Can it, if you have an underlying condition with platelets and you have ITP or some reactionary disease on top of the androgens on top, of course, very rare. Steroids have an isolated effect on the red blood cell line. Then you look at the increase. Number one side effect from testosterone, erythrocytosis. Even a woman who takes a little Anavar, her red blood cells go up. Now, are they too much? That's fingerprint dependent. Now, the upper limit normal of hemoglobin and hematocrit is not 17 and 50 like most of the labs. It's 18 and 54. And this is a standard now that has been adopted by the American Urologic Association and the endocrinologists. Because of course I follow those guys, but I've taken it to a different level. Okay, this is hematology. It's not urology, it's isolated, and it's not isolated endocrinology. It's cardiology, nephrology. Here we are, right? You know who the hypertension experts are? They're nephrologists and maybe endocrinologists, but mainly endocrinologists are obesity diabeticologists. I'm here to help you guys. So again, things with AI and things are tightening down. So we have a lot of information. I mean, there's 7 doctors for the eye. There's 10 doctors for the heart now. I mean, we're beyond. It's going to be crazy. So you better understand what to do for yourself and the technology is not going to be cheap. You don't want to be in the hospital. You don't want to be in the hospital ever. You can stay out of the hospital. Hypertension, A, B, C, Ds. Okay, sir, you can come to testosteronology. You could understand your hemoglobin, your hematocrit, your androgen-induced erythrocytosis with D on your own level with your labs. You ask questions. Me and my testosteronologist respond to your questions, and you get great answers. Okay, next question, Mark. I was the guy who you answered about PFS. Can I ask why time doesn't explain PFS? I want not even lose. Okay, so post-finasteride syndrome, losing hair, subtopicals. When I kept reading PSF forms. I tried to. Okay, so let me just look at your question here. So I remember you, sir, but I got a lot in my brain running around. I do remember this though. I remember seeing this you somewhere. Was it on the Instagram? Was it on one of the lives I was on? Okay, or were you on the health portal? Can I ask why my time doesn't explain? I was not even sir. Can you come on? Why don't we answer another? Oh, this is okay. I know who this is. Right. I think I gave you a very detailed answer, sir. I think that's on there. So come on the stage, sir. If you don't mind. I mean, if you don't want to, it's up to you. But come on, if you don't want to. Otherwise, I'll just answer questions inside the health portal because I remember you're in the health portal. So please look at the response I gave. Steve, didn't we have this posted back for the guy? Did we have the last? Sir, I responded to. Right, check your account, sir. I made a video just for you inside the thing. Okay, let's see. Thomas Aquinas. TRT to treat depression in 20s. I have had levels in 400 since I've been 16 and have had low T-sim. Wow. This is a great question, sir. I have to be careful because I'm not your doctor here. Absolutely. We have when you look at the nomogram, for testosterone numbers, there's total and free. Let's just go to total, 250 to 1100. And we know that one size doesn't fit all. And when you're a teenager in your 20s, 400, again, if it's repeated over and over, if you check it multiple times and you're 400, unless your sexually binding globulin is very low, and therefore your free levels are much higher, Thomas Aquinas, that could be something specific. Why don't you get into the health portal, give all your information, and then myself and my testosteronologist, we can evaluate it for you. Again, it's not advice. It's a medical. It's a forum for educational responses. It's not advice. Very careful about that here legally. But I'm not trying to play a game here, guys. I just don't want to get sued. So it's not a question for you. It's giving, here's a question. Here's how I would answer it. Do what you want to do, all of yous. Speaking on only for me, TRT cured 40 years of savage depression almost overnight. God bless you, sir. TRT. So back with the androgel, when the Fed cleared androgel, guys, 25 years ago, I don't even know. I was a resident. It was out there. They lit, and things have changed so great and so much. Androgel, these naysayers, testosterone doesn't work, it doesn't happen. Oh my Lord! And the data, this is randomized clinical trial. This is prospective, randomized, and double-blinded. This is the Holy Grail. It showed that men that had depression, double-blinded and randomized, that they gave them testosterone and it improved their depression scores. Now, I've been doing this stuff for a long time. I think it's a happy drug for most men, but I could tell you there's no panacea to anything. And men that have very tough depression that's with anxiety. Depression and anxiety you can't tease out. Depression and anxiety come together. And I'm not a psychiatrist, but I'm a primary care doctor, and I'm a guy that's been around for a long time. I've seen a lot of depression in my practice, in my own personal life. I've even had depression myself. You can't tease out depression from anxiety, right? So when you give testosterone, it can cure some of the anhedonia. It can cure some of the lows, but does it make you manic? Does it make you anxious and short? Yeah, potentially. But that's why you just don't check your estrogen. You have to check your ABCDs. You have to understand what you're doing. I cannot speak enough on understanding every aspect of testosteronology, from the mental aspects right down to the physical heart. And just, I work from the chin down, right? From the chin up is the mental stuff. I work from the chin down because I'm good for not having a heart attack. I've just decided that's what I'm going to focus on. So that's a great, and if this young guy has really 400 repeatedly, you need to get a great history and physical. You need to get a great evaluation by one of my testosteronologists. Again, but we could help you on the health portal, but in the end of the day, I have a provider list that are the top, highest quality providers in the world that are here to serve and service all of those that are on testosterone and steroids. It's not endocrinology. I can do diabetes, I can do osteoporosis, I can do women and men. No, this is just testosteronology. Okay? And that's the health consortium. And we're looking for the best doctors and nurse practitioners all over the world on my Testosteronology Society. And of course, we are servicing the members on the Testosteronology Health Portal. Next question, please. How to mix GH with bacteriostatic water? I don't know, sir. There's so many videos on the internet about that. Okay, thank you, sir. So Chemi, 53% lower is normal. So I guess you're talking about the hematocrit. It's 54. That's okay. 54%. It's less than or equal to 54%. It's technically normal. I mean, if you're living, we have healthcare providers that are all over the world, right? We have a bunch of providers that are in Revitalized Health. In help, is it Revitalized? I think my brain's working. And great guy, John. What a sweetheart and what a brilliant testosteronologist and a great healthcare provider. He's in Colorado, and when we started working together over 2 years ago, we share our cases, on these private meetings called the Grand Rounds. And we started seeing this guy saying, guys, a lot of my patients start with hemoglobins at 17 the baseline. Hematocrits of 52. And they're going to go up. They're living at 7,000 feet elevation. That's called hypoxic drive. That's why testosteronology is a full daytime job. It's not just wing it and just dump blood. I mean, you're not going to, if your clinic is doing that, you need to go to one of my testosteronologists if you care really about sustainable health. Okay, let's keep going. But it's 54. It's less than 54. I keep seeing people talking about lower risk when using Masteron at several hundred milligrams. When running 300 milligrams of test a week and adding 100 mass give a noticeable boost. Woo! Josh. All right, Josh. You're a young guy. So this is an old school testosterone and DHT, Masteron, testosterone and Primobolan. Those are the big ones, right? Arnold doesn't have to sue me because he's told people and everyone knows that his regimen was testosterone and Primobolan. I mean, and he got the real stuff because it wasn't illegal. Doctors were prescribing it back then. So, and he did little baby doses of deep oil. I think he said he took 10 milligrams here and there. I think we can all understand he probably took more than that, but he's still alive and he's 80. He's walking, talking, wheeling and dealing. So the combination of testosterone with a DHT derived steroid like Masteron is a phenomenal. Again, I'd be careful. I don't want to get too excited. It's a classic combination, and I think in the future, if we had regulated steroids, I think for adults, I think that will be one of the combinations that, because we know that it has some anti-estrogenic effects. Now, mood effects can be phenomenal, but you know what? We're men. You're on testosterone. You're stimulating the central nervous center. You're horny already on the testosterone that you're injecting. Some guys get too horny. Some guys get up and down, moody and horny, and they have erectile dysfunction. Welcome to the world of fingerprints. This is my life. This is my whole world that I've dedicated professionally to taking care of men. Erectile dysfunction is common. And then they add a DHT-derived compound like Masteron, and they feel great. And for a while, maybe weeks, maybe months, on and off. And then they come to me because they're like, Doc, I'm on test and Masteron. And you're right. I mean, the average dose of Masteron, again, who are you? If you're a pro bodybuilder, these guys could go up to a gram of Masteron, 300, 300, 300, right? 900. And they do it all the time. They love Masteron and Primobolan. One of the problems is, where are you getting it? And the quality right now, because of the logistical issues in the Asian market, because of the underground, the markets, and because of the China issues with the fentanyl. I'm not kidding. This is fascinating information. It really had an effect. You probably know that, right? I'm in the know, dude. I'm in the know that it affected the distribution and the production. It's all underground. It's a multi-billion-dollar market of Masteron and Primobolan. I don't know if that's come back. I'm not in those markets anymore. TRT saved me. Let me say that again, Mark. TRT saved me and gave me my life back. God bless you, sir. Me too, man. Me too, guys. That's why when you're on testosterone, you're never going to come off. That's it. Once you're like, okay, I'm never going to. And if you're young and you're like, whoa, wait, I'm never going to come off, don't do it. You're never, if anyone tells you, we're just going to like charge you up and give you a try. No. Once you get on it, if you don't like it, you're done. That's a trial. You're finished. Get out of here, sir. Do something else. If you like it, look, we're men. We're not the brightest bulbs in the tree. Our brains are very low-grained, low-browed. Okay, when you give androgens to the brain, most men, it is what it is. Come on, I have to make fun of it but you're never going to stop taking it, and therefore you better understand the effects on your health, including blood pressure. I love roids, and Doc's advice has been very helpful. Thank you so much, sir. Thank you so much. I love you guys so much too. And I know you love roids, but I want to make sure you don't have any health consequences. So easy as she goes, brother, but I do love you for that. Next question, Mark. Let's go. I keep seeing people talking about, that's the next one. Okay. Hey, Doc. Post-cycle therapy phase after 4 to 5 months, TRT, looking to get fertility back. Okay. Currently on HCG and enclomiphene, considering HMG and kisspeptin. How long should great question. Healthy male, 30. Okay, this is a great question. This is my technical stuff. So PCT phase 4 months. So you're off TRT. You're on HCG and enclomiphene. The dose, probably, if I'm gambling, HCG dose has got to be, you got to come off testosterone completely, sir. Don't add it. It's a mess. Come off TRT completely. HCG, if I'm gambling in Vegas, if you're the average bear, like a patient of mine, 1,500 units every other day. Enclomiphene, 12 milligrams every other day. Don't take it together hold on. We don't take the SERMs every day because of downregulation from the clomiphene data. We assume enclomiphene is more fitting for the receptor, but it's still going to be fraught with downregulation. So the urology experts that I know, that I work with on fertility on this every day, would recommend every other day. And clomiphene, it's more powerful than clomiphene, hopefully with less side effects. So HCG and clomiphene, got it. Dude, HMG, unbelievable. Where are you getting it? Here, you know what we have in America? On Trump RX. We have Gonal F. That is HMG. It's not HMG, but it's probably better than HMG. This is a good question. This is where you guys are tapping into to my brain, where this is my day job. So HMG, human mammillary gonadotropin, FSH analog versus the LH analog of HCG, and you're just rebuilding, right? So you're just hitting those receptors, Leydig and Serotoli, voila. And you're also driving the brain with a selective estrogen receptor modulator of enclomiphene. So it's guys that will do all this, it's going to work like a charm, sir. But with the enclomiphene, are you going to get depressed? You see, guys that have been exposed. Mark, put that back up again. Let me just see that one. So considering Kisspeptin, I love Kisspeptin. It's kind of like overall, it does improve the receptors with the LH and FSH. But I mean, you can throw Kisspeptin in. It's just like it's sprinkled in on the top. And how long should it take to regain fertility? This is God, a question for God. That what you're doing is just increasing the chances of you're producing more semen, right? Because when you're on testosterone and steroids, imagine, I don't know how, what, right? You're in your 30s, so you're young now. But what if you have a varicocele? What if you've been on gear for 10 years? You're 30. Maybe you could have been on gear. Well, start at 20. So maybe you're on gear for 10 years. How much have you been exposed? This is in my medical practice. I have to take all these variables in. And then I put together my own regimen. I do very well. So I would give, for a guy like you, a 90% chance in the first 4 months, because now get ready for this, sir. If this is your first child, your whole life is revolving around ovulation cycles. Remember, you're giving your whole life over to the woman, and don't argue that, sir. Don't argue that. So you want to have kids? That's the mama. So you're going to see she's going to be ovulating. She's running the show, dude. You're just going to make all the money, hopefully, and take care of the family. I don't want you to have a heart attack. Next question, sir. That's a good question. So good luck with all that, sir. I mean, let me know how all that works out. And if you don't get fertile in 4 months, 4 ovulation cycles, get a semen analysis, come back on board and let us know what things are looking like. I do this every day in my medical practice for over 20 years, and it's wild. Is it possible to do weekly tests on decanate injections if we want to maintain stable? No. Just let's go into the data. Testosterone undecanate, longest acting biologic testosterone ester on the planet. Half-life testosterone undecanate. Let's see. Omar taught me this, and 33 days. Half-life of cypionate and nanthate, a week or so, 7 days, right? And nanthate's a little less. So you don't need, listen to this, when you're microdosing undecanate, because the half-life is so long, it's going to build up and build. This is a great question. It's going to build up and build up and build. The half-life is a month. So when you're dude, don't do that. I don't like undecanate. I don't like undecanate injections, and I don't like undecanate pills for a lot of other reasons. I just don't like them. Maybe they're going to end up being better for some specialized group, maybe someone who's young, because when you take undecanate pills, it potentially can have a less effect on the hypothalamus pituitary gonadal axis. But then again, in the end, the guys don't feel it as good as just old school injections of cypionate and nanthate and Sustanon 250. Just old school. No one can argue the streets of mass, the streets of time, the streets of people, the streets of the feet. You just can't, because that's just decades and decades. It's just hundreds of millions of man years of just steroid use in the streets. I did a video on the YouTube channel years ago called Why Testosterone Injections Are King. And I did a whole breakdown versus everything else. So do not microdose like that. You can do whatever you want, sir. But just why would you use undecanate when you just go to a moderate ester like cypionate or nanthate or Sustanon 250? I just don't like you can't control it, sir. You can't control it. You're going to go all over. You're going to be swings up and not good. It's going to build up too much. Okay. Next question, please. That's a good question. That's a great question. Thoughts on telmisartan? Telmisartan, inarguably the best angiotensinogen receptor blocking hypertensive med on the planet. I've done a lot of videos on it. It's in the category of first line agents, ACE and ARB. It's an angiotensin receptor blocker. It's an unbelievable drug. I've been on it for decades, well, maybe a decade, and it is a PPAR gamma. It has cardiovascular endothelial. It has so many specialized effects on top of being a very, very well tolerated drug. But the beauty and the curse of telmisartan is that it's not that strong. And that's why it's such a good blood pressure medicine. It's well tolerated for most everyone as a first line agent. And then the truth is you add little baby doses of secondary agents to telmisartan. You could learn all this, and we could all help you with these questions on the Testosteronology Health Portal. So I love telmisartan. And telmisartan, I've done videos on this. One of the reasons why telmisartan is great, but along the lines of ARBs and ACE inhibitors like losartan, irbesartan, those are the ARBs that are similar. That telmisartan has had a pronounced effect on reducing erythrocytosis. So I thought years ago, if I could use one drug and hit three birds, so you're on testosterone, you're maybe hypertensive, and you want to protect your heart and your kidney, you're not going to use hydrochlorothiazide or indapamide, right, or amlodipine, certainly not metoprolol, and not even one of the ACE inhibitors like ramipril and lisinopril. You're going to go for this one because it will dampen down the effects of the red blood cell buildup. And you can fact check that. This is what I've done, guys. When you spend your whole day just doing men on testosterone and steroids as an internist, this is the kind of level that you come, because I'm doing the same thing over. All I do is ABCDs, ABCD, ABCD, ABC, and we have these medicines that with AI now I just start to cross-reference, and it's just freakish. Telmisartan is a great drug. Next question. Doc, any thoughts on T ratio E2 blood pressure? Ooh, I like that. What is a sweet spot? Mitigate risk cardiovascular. Oh, what a question. Victor Serrano. Oh my God. Of course, it's a doctor asking this question. This is a smart guy. He's trying to trick me, this guy. I love this guy. So that's a great point, doctor. Is there a ratio issue? I mean, what are you measuring? Are you measuring just total testosterone versus ultra-sensitive estradiol? You see, doctor? I mean, we'd have to get, essentially, I agree, and I understand your question. Looking at testosterone to some estrogen ratio, there's no question that there's going to be a balance for every person for blood pressure, because you know that ratio, the effects of testosterone, as I did in my presentation, I'm not sure if you were here for the presentation, if you look at the effects of androgens, not to mention the downstream effects of aromatization. So estrogen is going to have negative consequences on multiple systems. But when you look at blood pressure, doctor, as you're a great internist, it's affecting the RAS system. So you're getting that intravascular edema. You're getting that intravascular change that we know is modulated through the renal tube. Very bad. And again, that's why in the end, heart failure is spironolactone, right? That's why how we modulate that system when people are going into heart failure and they're just fluid overloaded, right? With the cardiorenal, doctor, the cardiorenal. So again, I've been writing and thinking about this for years, 20 years ago, before I came up with the ABCDs, and it was so simple and it was just right there. And I thought, this is what you have to get the ABCDs down. So again, I don't look at those ratios because I just don't, they don't really sustain, and I don't implement them for management of my patients. What I do is I keep things tight. I keep it to a down low. Guy feels good. I don't give little baby doses of testosterone. I give proper doses. And then I keep the ABCDs tight, including estrogen. And when I want to modulate estrogen, I don't only modulate with aromatase inhibitors. You know that. I know you don't do that either, or we try not to use those AIs because they're not sustainable and they have very bad effects. And men don't even feel good on them. So what are you going to use them for? The erections are bad, and it's popping tendons. And I mean, it's a very dangerous drug for the cardiovascular system for women that are using it, and they have breast cancer, but they're using it because they don't want to die from breast cancer. So let's be careful with the heart. I mean, let's be careful. You got to prioritize, right? Metastatic breast cancer. Hopefully let's not have a heart attack. This is a lot of people just don't understand the utility and where these drugs come from, the aromatase inhibitors. And estrogen, is beautiful for the brain, but it's not, is it too much? Are you moody and anxious, and not to mention puffy and edematous and hypertensive? You cut the sodium, cut down the testosterone, and then we do go into use telmisartan. I like a little indapamide. It's unbelievable. And I like my Nebivolol, and I'm on Jardiance, and I'm on Repatha. But this is just what I do. And I have access to it all. And for me, it's just unbelievable for my brain and for, my heart health, my kidney, I don't want to be weird, but it's like my erection system at 62 is freakish, because my nitric oxide and my endothelial health I wish I could just tell the world. Wait a minute, I am telling the world. It's just, it's true. If you keep your ABCs tight as shit, by hook or by crook, and you know how to use some of this technology, it's nitric oxide. All right, next question. Thank you so much, Dr. Serrano. So glad he's here today. Estradiol has a diuretic effect after the initial aldosterone compensatory period and relations nitric. Why do people still want to block it? Hell, I want to load it hard. Dude, this is Jeremy. We got some smart guys. Estradiol diuretic effect after initial aldosterone. I've read about some of that stuff. So after the initial aldosterone, okay, we got to lower the we got to lower the concepts here, because I love this, sir, and I agree. Estrogen is perfect, but some guys, everyone wants to block when they see that estrogen, Jerry. It's all my estrogen. I'm losing money, my estrogen. I'm snappy, my estrogen. My erections, my estrogen. Meanwhile, 20 years ago, when I was the anabolic doc in the beginning in Connecticut, right out of New York, guys were coming to me and they were on Test and D-ball, the most estrogenic compounds you could possibly get. I don't even know if we had estrogen ultra sensitive in the lab. I don't think we even had it. Total estrogen. And I don't think I was even measuring it. But I was like, how do you feel, sir? And they were like, holy shit. And I was like, wow, you're on like a gram of testosterone. You're taking, these are more power lifters I had. The bodybuilders really quickly got upset with me because I wasn't giving a blessing on all their craziness with the insulin and all. I was like, get out of here, guys. I'm not putting up. I'm just a guy who just wants to do a little steroids, bench, squat, and deadlift, and just have a beer. That's just and be a decent dad and not be a narcissist. I'm sorry. And it's just like, I just was like, get out. So guys came to me who just brothers from different mothers and just want to do some steroids and be strong as shit and walk around. Hey, what's going on, guys? And just want to be big and strong. And they took estrogenic compounds. And I saw the majority of men on these estrogenic compounds had the best sex in the world. But then you start to see the breakdown with the mental health issues and the underlying mood disorders. It is true. And that's why you microdose. And that's just, and you have to isolate. All I do in my medical practice, I isolate the vectors. A, B, C, Ds. Let's isolate this. How do you feel on that? And you see, as a detective, I'm isolating these vectors. Again, it's easy for me because it's all I do. And I'm an internist, so I've been doing it since the 90s, like 1997. I was in medical school. So it's like, it's kind of and I was on steroids before. So I just understand the whole thing from a cardiovascular internal medicine perspective. And then we didn't have any of this. We had no internet back then. I know we had the beginnings of internet. We had the dial-up. It was just, here we are. All right, next questions. But thank you so much, Jerry. That was great. Thoughts on HCG? Is it needed protocol? Love you, sir. Boston, Sean. Okay, thoughts on HCG. It's definitely not needed, but it can be used. don't just, there's no cookie cutter. There's no protocol from the textbook. So protocol for major atrophy. So I'm trying to look at this guy. All right. So I don't want to profile. This guy looks great though. Holy shit. Look at this guy. All right. So when guys start on steroids and or testosterone and they don't, who the hell wants their balls to shrink? I remember when I was doing steroids, they were aching. And I was like, is this normal? They were like, that's normal, Tom. I was like, back in the 80s, right? Late 80s. I was like, oh my God, this is normal. I was like, oh, holy shit. I mean, so if you want to maintain your testicles from the get-go, once you're on steroids and testosterone for a couple of years, sir, and once you've had the atrophy, I'm not saying HCG doesn't work, but you're going to see, and as you probably know, if you've experienced this long enough, guys do HCG, right? You start testosterone, you either take 250, right, or 400, maybe 750, which I did a question on a guy in the health portal yesterday. He's on 750, 150 of test. He's on 90 of Masteron for the anti-estrogenic effects, which be careful with that. That's kind of new stuff, but not new, but it's out there more and more. And he's on HCG 250 3 times a week, right? 750. Now, you have to understand, guys, it's going to work on the testicle. You're going to have your cum shot is going to go up. Your ejaculate goes up. Your balls will stabilize. They'll even grow. I mean, it just does. But if you stay on it years and years or on and off for years, most men, we have no data for this. It's all anecdotal, just like me and my business for 20 something years with over 10,000 patients I've had in and out for all this time. And I've talked to more and more on podcasts and do all this stuff. Most men don't stay on it for a lot of reasons, sir. It's expensive. It's a pain in the neck. You got to inject it. It's all these injections. Come on. If you're traveling, you got to put it on you got, excuse me, stewardess, I need a freezer bag because I have these are my drugs and we need to put them in the refrigerator. Or this is my refrigerator bag. I have to have it here in first class with me, ma'am. Get out of here, sir. So, I mean, this is just, you have to reconstitute it. It's got to be in the refrigerator. It's just a deal killer for a lot of guys, okay? So they end up giving up on it and they realize it ain't so bad. But our testicles are smaller. But if your brain is working in your limbic sexual center and you're either not on too much steroids or it's something that doesn't bother you and makes you sexual, you don't really need testicles to have an erection. Shh, we don't want to get the secret. That's a secret. Okay. Well, it's not a secret. It's just something like, really? It's true. It's just true. Quick, really funny story. I started dating Nurse Wendy. She hates when I tell this, but I have to tell it. Dating Nurse Wendy back in the day in the hospitals. And I was in my hospital walking around with my lab coat and my tie on. Hey, how you doing? No one really knew I was the anabolic doc. That was kind of like my double life. And she's the interventional cardiology nurse. And she was my girlfriend for a few months. Really fell just incredibly in love. And I was so happy. And I would go visit her at the nursing station. And all her nurses, oh my God, here's Dr. O'Connor. This is a big hospital, St. Francis Hospital in Hartford, Connecticut. And I would come up, with my suit on. Hey, I'd come, Nurse Wendy, can I take you out for lunch today? And one day they were all looking at me and they were red, they were laughing and smiling, and they were kind of looking down at my pelvis. Long story short, I go, what the hell is going on with that? And she told me a few days later, I told the girls, the nurses, that you should date one of these steroid users because they have these little balls that are all tucked away, because now remember, these are interventional cardiology nurses, all the caths, they do most of these in the pelvis, and they have to shave around the man's testicles. And if you're a nurse and these guys have these big, nasty, guys, I have to be fun. And so she's like, these guys, these steroid users, because she had a good life, but she's a good girl, and she had a few boyfriends, right? And just mind me saying that. And she's like, these guys have these big balls. They're these little tucked away testicles, and they don't get in the way. They're just there. I said, holy shit, you didn't tell. Well, she did tell them that. So you don't need, even people. You have like little testicles, but your erections can be great. Voila. But if you don't want little testicles, don't take testosterone or steroids until you're ready to do it. And if you're going to do it and take HCG, it's going to work. But in the end, no one is on HCG for life. Okay, hope I answered your question, sir. So stay on it, but be careful. Again, testosterone and HCG is estrogenic, and it leads to edema and hypertension. And it doesn't work. It loses the effects. I use it essentially for guys like you that want it, and I give it to you for the wellness. And I use it incredibly often in my everyday. We probably refilled 75 scripts today for younger men that are in a fertility mode. Okay, because it's the standard of care, with or without clomiphene and or gonal F. I get steroid users fertile. I mean, that's what I do. All right, next question. Your opinion on TRT while taking peptides. My blood pressure has dropped by 20 points on top of bottom and reading 124/68 in less than 1 week on Retta. Awesome, dude. Looks like you're about 9 years old in that picture. That's okay. So TRT, sir, Mike, peptides I remember 10 years ago or 5 years ago, peptides were kind of, they were just ipamorelin and this, they were just kind of more limited, like the secretagogues and some SARMs were thrown in there. And now it's morphed to include, it's unreal, CJC 1295, ipamorelin, Somorelin, more secretagogues, MK 677. I'm just going to go off my photographic memory if I have anything left after this long day. TB 500, TB 500, all these healing peptides. My memory seems to fail me. And they're just peptides, but they're really not peptides. Some of them are peptide agents, but they're just a host of so many PT141, right? All this stuff. There's so many. And Retta is really just tirzepatide with glucagon, and it's not out. This is gonna be probably the one of his biggest drugs. And now, what are you guys gonna do when it's actually a multi-billion-dollar drug by Eli Lilly? And I mean, I just think it's funny that everyone's into peptides. BPC 157 TB 500 healing peptide. I think they're great, but I want to see the data. I want someone to prove to me, and I'm a doctor that I took an oath. I stand by it, that I need to be honest and I need to see the science. So I need randomized clinical trials, guys, RCT. And as physicians and healthcare providers, we're there to protect you, your family, cancer, trauma, horrible things that happen to people in hospitals. You have to be honest with people. And all we do is this of our specialty, and we have to have guidelines. We have to agree that we can't run on chaos. And I'm not saying this is all chaos, but come on, guys, on the internet, every little social media guy, boom, 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 and they're not doctors. And shame on the good doctors that have kind of quit their jobs and they're selling garbage now. Again, I'm not here for politics. There should, again, like background checks. What are you doing? Like, who is this person? What are they saying? So Retta is an incredible agent. It's hopefully going to come out soon. I hope Lilly doesn't make it a biologic. Here's a little secret for you. These guys are waiting for the FDA. The FDA is waiting for them. They already have clearance, supposedly. They're dragging their feet because they want to make it a biologic agent because of the nature of the triple compound, I assume. It's not just a double, GIP, GLP. It's got glucagon. And if they make this thing a biologic agent, they're going to be able to get a lot more money for it. And I think we already see problems with GLPs like semaglutide and tirzepatide as far as the ethical accessibility by people that need them. And they're not accessible because they're too expensive. So you have to go to this other markets. In my opinion, that's disgusting. And in America, if I can do anything about it politically, I will. because it's disgusting. And I don't want to say socialized medicine, guys. I just want to see these agents more accessible to people. Do something about it. God damn it. It's a man-made event. Do it. We could do this like that if we wanted to. So, and again, I'm not going after Trump or any one of these. I'm just saying it's just do it. We need people to. Do you understand the epidemic of unfathomable obesity and just medical failure, catastrophic failure, and the unbelievable chaos and pain and suffering that we see right now? We're going to collapse under this, guys. We need people to get in better shape. I like RFK with his help, Make America Healthy. I'm not going to joke about that. But do you really think RFK is worth how many millions and millions and millions and millions and millions and millions? And he comes from a great social economic background. And again, I'm not against this guy, okay? But it's not feasible when people are so massively sick with eating too much, and just we need these medicines to be more accessible to people because we know how they work. We know they're protective. We know they're unbelievably protective on obesity, cardiovascular disease, kidney disease. I don't think you guys know that, and therefore it should be in the water for people who want it. You don't make people take it just if they want it. I don't get it, guy. But thank you for letting me go off. So Retta, too, good for you, Retta. I think Retta's great. I hope it becomes a real drug and you can get it. And it's going to be really. I like brand names. If I'm buying my wife something, I'm just going to go to Chanel. Why would I waste any time? All right. So can TRT cause prostatitis? Let me hold off on that for a second. Think prostatitis. Let's talk about prostatitis. It's an inflammation of the prostate. I've seen it a million times, right, as a doctor, a primary care doctor. So let's talk about TRT. Androgens affect the prostate. With the grace of God, they don't cause prostate cancer. Now, to some doctors who don't know that, they should walk away and they should relinquish their license. Just years ago, good doctors, testosterone can cause prostate cancer. That's an unbelievable misinformation, embarrassing statement, because there's no way it causes prostate cancer. However, it affects the prostate. If you have cancer, could it worsen it? How do you like that? Okay, that's a malignancy of the prostate. Next, prostate enlargement. Now we're going to go into prostate enlargement, BPH, and prostatitis. Because again, this is my day job, and I dealt with this today on probably 3 patients, differentiating BPH, not cancer. And if I don't know it, which a lot of times I don't know it, I have to work with a urologist. That's why I've never had a lawsuit, never a claim, never even a tire kicker. And I'm proud about that because I don't take too many patients, and I take my time. And if I don't know something, I'm careful, and I make sure that my staff in my office coordinate care with other healthcare providers because I don't know everything. And I make sure I'm a manager, and I button things up for people. And that's how it used to be. So that's unfortunate now. And that's what this healthcare system is going to help you do, hopefully. But you got to put the energy into it yourself, damn it. So prostatitis, sir, testosterone? No. But can testosterone and androgens, especially DHT-derived androgens, worsen underlying conditions called BP? Absolutely. I have had probably half a dozen, maybe more, men under the age of 40, some under the age of 30, have to get their prostate bored out with a roto-rooter called a TURP, TURP, transurethral percutaneous transection. This is a rotor-rotor. This is an old man, typically, who has a boggy, big BPH prostate, not cancer, and he can't pee, and he's in the ER. This is where I used to work. And we call urology, and they come down, they tee him up. Of course, they have the Coude catheter in the guy, if they can get it in. Usually there's a good nurse that can figure out, there's a special catheter to go, it's no joke. And then they tee the guy up, and they bring him to the OR, and they bore out that prostate. And I've seen this. Now we have less invasive procedures, right, for BPH, but steroids can, and again, depending on your fingerprint, how old you are, how much androgens you've been exposed. My prostate's quite enlarged. It is. I don't have cancer with the grace of God. Woo! But I suffer at my age from an exacerbated BPH, from a prostate that's, my prostate's more hyperplasiaed than it would be if I didn't do steroids. But with the grace of God, it's not that bad. Right. And I know how to get around it. And I don't take steroids anymore, just testosterone. Some men can't take testosterone because of the effects on the BPH, benign prostatic hyperplasia. Now, prostatitis is an inflammation from the prostate, in the prostate. Now, it can happen from a urinary tract infection. It can happen from just pelvic inflammatory, right? Sexually transmitted diseases, urethritis, epididymitis. This is my world. Last week, we had like 3 guys come back from not just Vegas, and we had to sterilize them with STD medication. The guys who work in my wife, my nurse, and my manager have memorized all the STD panels at Quest and LabCorp, and because we just take care of men, and I'm not proud of this, and they understand how to treat the current day and age for syphilis, gonorrhea, and chlamydia, because we have men that are men and they're on testosterone, and even men without not being on testosterone. And these are not all young guys. So anyway, and some of those guys have urethritis and they have prostatitis. So when you have prostatitis, that, in my opinion, needs to be diagnosed by a differential diagnosis of exclusion from a urologist that says it's not cancer, it's not BPH, it's inflamed, it's prostatitis. Now, a lot of times, prostatitis, they don't know. There's no etiology, and you can fact check that. And that's when the doctors, these are good doctors, that they start giving antibiotics like fluoroquinolones. Again, I've been around for a long time, guys, and I've always kind of pushed them back on that because I don't like fluoroquinolones. I don't like antibiotics if we're not nailing down something very specific, because we have a massive epidemic of resistant bacteria. I think everyone knows that because of indiscriminate use of Z-Packs, and everyone wants, you have a virus and you're giving a freaking Z-Pack. I mean, come on. I know it's not perfect. People want, that lady wants the Z-Pack and she's just not going to leave the office until she gets her Z-Pack. I mean, even though it ain't going to work, lady, it's not, this is a lot of politics on this stuff, right, guys? There's some human hand waving on this. I used to be a primary care doctor. I had to give the Z-Pack too. Of course, I would try my best not to. And if I really thought it wasn't needed, I wouldn't give it. But sometimes they just want that Z-Pack. Oh, it's so bad. But you don't want to give antibiotics for, they're saying it's chronic prostatitis, and they're giving Bactrim, they're giving ciprofloxacin, Levaquin. I've been there. These drugs can rupture tendons. I don't like that. And I don't like the fact that they cause just systemic growth, irritable bowel syndrome, small bacterial overgrowth. God, it's not a perfect world. Again, I don't like inappropriate use of antibiotics, but I'm a prima donna now. I don't give antibiotics anymore because I don't do primary care unless the guy has a skin infection from an injection, and I'll use whatever I think is good for him. Catflex, Bactrim. It's very rare that I use a fluoroquinolone. Okay, next question. So prostatitis, 140 milligrams a week, 140 a week with 2 injections. So that's 70 times 2, right? So estradiol in range, but back knee is getting severe. No other real side effects. I'm feeling great. Advice. I can't give advice, but I'm going to give you an example, sir. I'm trying to think. It's been a long day. So what we give, what my practice would give is clindamycin, is benzaclen. So put that one up again, Mark. I want to give this guy, this is a great, I'm just going to roll with this. So when you see the back knee, right, you Obviously, there's some genetics on that. Not the estrogen. It's not just estrogen, guys. It's just androgen and DHT. But don't measure all this stuff. Keep your dose as low as you can, sir. That's not a crazy dose. Stay as tight as you can, and then so get your doctor. Or now in the next few months, we're going to have prescriptions on the Testosteronology Health Portal: Benzoclen, benzoyl peroxide, and clindamycin topical. This is an incredible first level for treating back knee with guys that have just a little moderate. This is not Accutane, right? So if you have cystic pustular acne, you got to go to a dermatologist. I work all day long with dermatologists. So Benzoclen, benzoyl peroxide, Benzoclen, twice a day, brother. I think that will help you. All right, let's keep going. Man, I gotta take what do I have? The Red Bull, but I have no sugar. Been up since 5 a.m, guys. Doc, what's your thought on clonidine patches over blood pressure pills for high blood pressure? My kidney doctor is recommending I try these as I had bad. Wow. Okay. Clonidine, central acting agent, clonidine, old school, definitely not first line, but clonidine, the pills and the patches can be a great additive when you're an expert in blood pressure like me. So thank you, sir. This is a great question. So now, sir, you have bigger new you. Sir, you have a kidney doctor. Kidney doctors are hypertension experts. You must have some kidney disease. So I want to be careful with you, sir, because you're recommending, so you had bad side effects with the pills. So I'm assuming you're already on a few other blood pressure medications and he's adding this because it's an add-on. It's not a first line agent. Clonidine would be an add-on, or very rarely it would be a first line if you can't tolerate anything. But can you please ask your doctor for me? Ask to make sure, are you on Jardiance or Farxiga? Do you have chronic kidney disease, sir? So many patients have chronic kidney disease, so many people, and they're not utilizing the modern technology that's evidence-based with PCSK9s and with there's two classes of meds that I have to talk about. There's, again, beyond the GLPs and the tirzepatides and the retatrutides that people have found, because they not only protect the heart and kidney, they cause weight loss, and people want that. There's two classes of drugs that I have to talk about. PCSK9, Repatha. Where is it? Oh my God, I have it. This is a statin sparing. If you can't get to goal with your cholesterol, you don't want to take too much statin. Maybe you can't. Your insurance company will pay for this because it's got primary prevention. This is an injection every 2 weeks. I've been on this thing for 10 years. I've reduced my heart disease. I have no symptoms. My cholesterol is so low that I can't build up anymore. Cholesterol is just one part of a multifactorial complexity of atherosclerosis. A, B, and C. I promise you guys, it's not bullshit. Don't believe the misinformation that cholesterol is a myth. It's bullshit, guys. It's complete bullshit. It's one of the modifiable risk factors. It's just one. It's just one of them. And we don't want to be toxic on statins. So this is a tool. I prescribe it all day long. But in my practice, I get my nurse and my manager to get it through the insurance company because we just browbeat them, and they just don't want to. I make a lot of noise, right? Squeaky wheel. So that's the problem right now. That there's no one in these clinics that knows how to do the pay. They don't even know about this. So many doctors and nurse practitioners, I go, do you know what that is? I have no idea what that is. Sodium glucose co-transporter inhibitors are great, sir. Right. So two classes of drugs, guys. Again, we're talking hypertension, but ABCs. So sodium glucose co-transporters, PCSK9 and sodium. I'm on both, guys. And it's been unbelievable, just unbelievable for my metrics and for my health and for my own markers. But it's expensive and I know how to use them. All right. Thank you so much, Solomon. I want you guys to understand this. Really, this new technology is going to be tough. There's going to be the haves and the have-nots, and I want you to be the haves. Having information. It's not really just money. If you want something in this country, you could have it. Forget the money. You could have information because we're letting you have it here. So, sir, go to your kidney doctor. The clonidine patch, I agree with. This is a nephrologist. Nephrologists are the experts of hypertension. Go to Google. What type of doctor is a hypertension expert? Nephrology. You're gonna see that. It's nephrology. They're not surgeons. Urologists are not hypertension experts. They're surgeons. It's nephrology, hypertension expert, or endocrinology. Most commonly, it's nephrology. You have a nephrologist. Ask him if Jardiance is going to be a great. Jardiance has incredible effects on modulating blood. It's not a blood pressure medicine, but it will modulate blood pressure. Go to your doctor. And I mean, do you have chronic kidney disease? Is it FSGS? Is it from steroids? There's hundreds and thousands, if not more, men that are out there, and even women that have heart disease, premature, and kidney disease from steroids. And they're just not getting picked up. I want to pick these people up early as we can. What is your opinion on half a milliliter of Testosterone 250 or 5? Half a mil of Testosterone 0.5, I think it's a little too much. I think 0.3 is better. So when I'm working with patients all over like the UK and Europe, and they have, do you guys know that the UK, I'm kind of jealous. Wait a minute, I'm very jealous. The UK on their social system, when you get testosterone, they don't give enanthate or cypionate. They give Testosterone 250. It's unbelievable. What's going on here, guys? So if I'm using Testosterone 250, right, the four esters, beautiful combination, classic and tried and true since the 1960s and 70s. Because it's 250 per mil and everything else here is 200, if I'm using 0.5 every 5, my correction is I go 0.3 or 0.35. You see? And then you give it to steady state, which is about 6 weeks or 8 weeks, and then check your levels and go by feel, and then go by ABCDs. Testosterone 250 is a great drug, man. Really great drug. Great TRT drug. And it's a great strength drug. I mean, we've all been in Testosterone. We all started back in the 90s and stuff. And then, the big boys back in the day, it's just Testosterone 250. And enanthate, of course, Isn't it amazing that nothing's really changed on that end? Because you can't, it's like, if you look at a pen today is very similar to the pen in the 1950s because you just can't make it any better. I know there's rolling balls. I know but and the ink but it's like the concept of a pencil or a pen. You just can't, you still need it. I think of this kind of stuff. And then you look at Sustanon, you look at enanthate and cypionate. I just don't see, until we can do gene editing and like edit the genes so you can produce more testosterone. Guys, I'm thinking I'm going to lose my job, but I'm thinking, how much time do I have? I don't know, probably 10 years. I mean, honey, get the banks ready. I don't know. I mean, gene editing comes, we're all finished. Don't hold your breath, guys, but it's coming. It's actually here right now. Some of the most expensive meds in the world, fact check this. What's the most expensive med in the world? It's one injection for a unfortunate newborn that has a horrible neurologic devastating disease. And they do one injection for $1.5 million, and it fixes the mutation. It's there. You can check it. Now, who pays for that? How does the insurance pay for it? I don't get it. I don't understand it. 1.5 mil, one injection. Let's keep going, guys. Next question. No questions, but thank you for all the information. Thank you. It helped me. Thank you so much, Bill. Dr. HCG definitely seems to help with mood and anecdotally, right? Brain fog. Guys, I agree. Taking HCG on top of testosterone, when you tweak those balls, when you just tap those balls to get them to produce endogenous testosterone on top of the exogenous testosterone injection, wonderful things can happen. It's really interesting. It really is, right? So, but again, is it sustain? It's not deadly. I mean, is it sustainable? It does cost some more money because you have to get pregnant, right? In this country, it's the government pulled it out. They made it a biologic around the COVID. And again, I don't know. I don't want to say the political stuff right now, but it's like they made it a biologic, and then none of us could get it from like Empower Pharmacy. It was, and now we have to go to specialized pharmacies, and it was like triple the cost. You guys know that it's called Pregnil, and it's brand name HCG. I didn't want brand name. I wanted just HCG, dude. Just make it in a good place, bro. And it was working great for 20 years. And then they just made it a bio. I mean, come on, guys. Tricky stuff going on here. So now it can be expensive. It's a lot of injections. And here's the truth, brother. Most guys that I see on testosterone HCG, if you're not doing it for fertility, with post-cycle therapy and coming on and off, you're a young guy. And if you're using it for that, good for you. But most guys in the beginning of the TRT journey, they do start with TRT and HCG, and I would recommend it. I would recommend it. I do it if a newbie guy. I don't take too many newbies. Most guys come to me in my practice when I'm taking patients, and I'm select, and I love that I take some patients. Most guys come to me on testosterone already for years, and they want to have me with the ABCDs. They just don't want to have a fucking heart attack. Excuse my French. Sorry, Steve. I cursed once. I did one. So we're trying to work on me on this. So I don't want to be a truck driver, New York City doctor, truck driver from New York City anymore. It's not going to go well. So trying to clean up my act here. So HCG is great. It's not going to be forever, but use it while you can, and then guys go on and off it during the year. I think that's great, the information that I could tell you. Again, some guys feel great because of the mood. Maybe it's the mixing of the endogenous with the exogenous and a little bit of estrogen. They just feel good. But sometimes at a certain point, I don't feel good now. But what else is happening in your life? I'm like one of my patients told me, I say, Doc, I know you say you work from the chin down, but you're really one of the best therapists I've ever had. And I'm like, I don't want to be your therapist, sir. All right, let's keep going. Next question. Oh, this is really fun. Elevated LP little a and ApoB and TRT use, no statin yet, 47 with consistent 200 cholesterol, decent shape. How do you feel about statins and TRT? Love this. Okay. Cholesterol 101, redo. 2026, American College of Cardiology, American Heart Association. They are saying now you really want to look at LP little a. Everyone wants LP little a is a very atherogenic marker, lipogenic particle that's not LDL, right? It's different, and it's genetic. It's genetic, and it's about 10% of Americans will have this. Apart from LDL, you'll typically see this when you have the family history that's pretty robust, where the father typically in the family has early heart disease. Again, beyond smoking and drinking and all this kind of environmental behavior stuff, you'll see, and you'll check the LP little L, and there's two metrics, and you want to look for those reference ranges on Testosteronology Health. We have all that. You could check that on. You don't even need to join the portal. There's labs outside the portal. I want everyone to have this. No doctor's prescription, and it's cheap as hell. There's no insurance. This is like $130, and you can check your cardiovascular markers, including ApoB, apolipoprotein B, technically is what it's called, ApoB, and LP little a. And now, so the LP little a is checked and cleared. Once you check it once, it's either perfect, or it's moderate or high. And then you really have to understand, do you realize? And you can fact check this. There's no diet and exercise will not affect LP little a. It won't, minimally. And do you realize statins won't affect it? The only thing that will affect it, but it's not really cleared for it yet, is this can reduce LP little a up to 20 to 30%. I'm not kidding. That makes it puts a dent in it. So if you have LP little a, you need to think your doctor needs to give you a PCSK9. And you want to fact check that and just bring the goddamn information in and say, doctor, here's the information from American College of Cardiology. Don't say me. Just bring it in yourself. I'm here to give you information. That's why the Lord put me in this seat right now, to give you very good sound information. And then everyone needs information. And then you back it up with the AI and the stuff, boom, boom, boom. And you go, there it is. I need it. And then if they don't want to play ball with you, get a new damn doctor. Get one of my doctors on the society. I'm training them for you. Let's keep going, guys. Okay, ApoB. Let's talk about ApoB. ApoB is a better predictor of cardiovascular. Mark, put it up again, please. Of health outcomes. It's a better predictor of health outcomes because it doesn't just cover LDL. It covers in part other atherogenic markers like IDL and VLDL and LP little a. So we again, I'm advanced on you guys. So we don't want to just look at LDL. You want to look at ApoB. So, sir, very smart. TRT use will not affect LP little a. Oh, wait a minute. I saw steroid users I have something to tell you. I have a steroid user so the steroid, I have like a 30-year-old steroid user that I do harm reduction for. I give him blood pressure medicines. I help him with his heart, and I tell him to constantly get off steroids. I don't give him testosterone, and I don't like to take too many of these guys, right? But I protect his heart. I think it's ethical. So that's what I do. This guy has an elevated LP little a. It's quite elevated, by the way. And he's using steroids against my advice. We looked at his LP little a, and he was on tren, equipoise, a gram of test. I saw something fascinating for the first time in my life. The HDL goes down. Steroids will diminish the production of HDL, that line out of the hepatocyte where all these lipids come from, the liver, the hepatocyte. And so that's bad, right? Because that's protective, right? The HDL. And steroids tank the HDL and they can increase the bad L. This is a horrible. That's why bodybuilders, steroid users, and one of the reasons, one of 20, why they have atherosclerotic premature, they accelerate heart disease. I did it to myself. We looked at his LP little a after big cycles of steroids. He did it. He was just doing his own labs here in Florida. And he said, Doc, look, I found something. Look at the steroid use. My LDL went up. My HDL went down, and my LP little a went down. There's nothing that treats LP little a. And then we thought, holy shit, anabolic steroids are treating LP little a. But is it worth it? No way, because of the other dangerous effects on the blood. You guys, I hope you guys like this. So here's what's happening. On that ice, like the stem cell lines, right, with the white blood cells, the red cells, and the platelets, the lipid, and this is all basic 101, right? Lipidology 101. That's something actually, I love lipidology. I study all this stuff, ABCDs. So when you look for the isolated stem cell lines that produce the genetic lines through the liver of HDL, LDL, all the cholesterol panels and LP little a, we know that steroids diminish some, and steroids are diminished. And I'm helping the biotech guys out, right? Maybe they don't know. So steroids reduced LP little a. It was incredible. But let's use steroids to protect the heart to take LP little a down. That doesn't make sense, but we're onto something. Okay, so sir, testosterone and steroids can absolutely have adverse effects on the cholesterol. Statins, here's my secret. A little bit of a statin is called go to Google AI, put in statins, pleiotropic, pleo, P-L-E-O, T-R-O-P-F-I-C, pleiotropic effects. you'll see that's apart from lipid lowering, statins are protective on stabilizing endothelial dangerous soft plaque because of anti-inflammation. You guys like that word, anti-inflammation. And they have other cytokine and other mechanisms that lead to cessation and quelling a dangerous plaque. Everyone, this is 101. This is internal medicine, cardiology, lipidology 101. So you want a little bit of a statin. I take 10 milligrams every other day, but I don't want too much because of the muscle effects. And they do cause diabetes and prediabetes. I don't want that effect, right? And then all the other effects potentially on the brain and all these kind of things, which I don't really agree with, but I'll say I agree. I know that can happen. So when you use this, no side effects with statins, this is a statin sparing agent. So this is why you have to come to this world of technology. And again, because I study this in a vacuum and I'm an internist from my development over 25 years ago, when these developments are all coming into play now, I'm just putting them all together. And this is, again, evidence-based. Everyone knows that, the American College of Cardiology, but it seems like it's a secret. You guys just don't have access to this. But if you fact check the guidelines and how to use statins, and if you can't use a statin, it says PCSK9, watch this. It says bempedoic acid, and it says azadia. Those are the ingredients that we use to get someone to goal. I mean, it's not much. Statins, combinations, every other day, low dose. You're not going to get to goal, but you could add this, which is my favorite, or I add a little Zadia, which is tried and true, and that's generic and cheap. And then we add bempedoic acid, which is unbelievable protective. And I use all this stuff with my patients. And then Vascepa. Vascepa is an unbelievably protective fish oil. It's a pharmaceutical grade EPA derived fish oil. Look at the reduce it. Go to Google, put in Vascepa, reduce it trial. Reduce -it, RUDUCE-IT. And you're going to see flabbergasting. I'm on all this. I'll take anything to protect my heart and kidneys and to kill it and to keep crushing it. Once steady state is reached, does it even matter what ester you microdose with? What a question. I don't think so. Right. So once you're at steady state, you have to understand. I mean, this is like an Omar, doctor. This is a Hajmosa PharmD question. So if you're looking at propionate, which is a shorter acting, the theory is it's at steady state, but there is still the kinetic up and down of it, right? So, but if you're working within the kinetic and you're really microdosing properly, in theory, you're going to understand the stability. And that's microdosing. And then there's your fingerprint. So you have to understand everyone has a different fingerprint for metabolizing these ester. So the ester chains, testosterone, the only difference that the chemists came up with in late 30s after the discovery into the 40s and 50s and 60s, they made thousands of different esters of testosterone, DHT, nandrolone. This is the steroid back in the steroid. This is my days, right? That the Anabolic Doc YouTube channel, I did, okay, I'm going to open a channel. I'm going to do every steroid, and they're on there, right? So there's like 25 steroids, then I did like Ment, and I went into all the, that's not the same, Ment is not, I know it's a steroid, but I don't want to think it's common, but I did Dynabol, Anavar, all the esters of testosterone, multiple videos. When you look at the kinetics and you understand there's propionate, there's cypionate and anthate-sustanon, there's undecanate, the long-acting. If you understand the kinetics on them and you're injecting appropriately, like you can't inject undec. I know guys have tried it, and some men, if you're doing it long enough and you're looking at it over time and you're injecting that ester undecanate very closely together, like you would microdose a moderate ester like cypionate or an anthate, it's going to build up. It's going to build up because you're dosing it within the half life, so you're just loading it. It's like a load. Again, there's no rocket science on this, and then that's why guys come to, whoa, look how high you're loading it, but there's also a variable of your own fingerprint. I call it this. There's fast burners and slow metabolizers. And of course, all guys come in. I'm a fast metabolizer, doctor, wink, wink. So they need more. And they wait to go to the lab for the nadir. And not many guys play this. Guys don't play that game with me anymore. But 20 years ago, they did. And I have guys in jail that used to tell me that in jail, they would take the 1 cc every week or 2 weeks, whatever the nurse, the infirmary would give them. And I've had like 20 guys incarcerated, and I was one of their medical. From the outside, I would tell the doctor what to do. And the mothers, the wives, I mean, I would just have consults, and the guy would come out of jail. Again, these weren't child molesters. They were just good dudes, but come on. I mean, they were incarcerated for drugs and stuff, and they were on steroids, and they're on steroids, and ethically, they needed to be on testosterone because they're going to crash and burn. And they're not back. They're in jail. So I would tell the doctor what to do. And some of these guys would rub out, and they would try to sponge out. I learned this from the prisoners, that they would sponge it out. They would go to the infirmary. I don't feel good. Well, what's wrong? My testosterone is going to be low. Can you check my testosterone, please? And they check the level, and he's low. And then they tell the medical director, and they end up getting on one guy was on 400 milligrams a week of I swear to God. And then he came to me and told me out when he was released, he told me that he did that. And I was like, holy shit, dude. Oh boy, come on, dude. But he was a wise guy. He ended up committing suicide, this poor guy. He succumbed to suicide after a couple years after being incarcerated. He had obviously mental health issues and drugs and things. But okay, guys, so hopefully I answered that question. Let's keep going, guys. Another question. I think I'm going to wrap up pretty soon. Man, brain is still going here. Hey, doc, you think the first line defense, chronic kidney disease, A or B, like Telwin is wow. Oof. So chronic kidney disease, first line, A or B, well, for blood. So kidney disease, most common cause of kidney disease in America is two things. Forget the congenital stuff. Like Chris Bumstead has IgA nephropathy. Fact check it. Again, he has this. He has that by birth. So doing steroids was, but he is what he is. You could fact Chris Bumstead, kidney disease. Go to Google. Okay, IgA nephropathy. We're not going to talk about that. Okay, standard kidney disease. Two things, dude: hypertension and diabetes. So if you go into a dialysis center in this country and you just look at all those sweethearts that are in there, if you go up to them and you said, why are you here? They had years of undiagnosed and horribly managed, if managed at all, diabetes and hypertension. You see why I want these medicines released to my people. This is ridiculous. So diabetes and hypertension. Now, let's go to a steroid guy. Steroids, the condition, and I'm one of the experts in the world on this stuff, guys. So if you go to Google and put in what type of kidney disease do steroids cause? Focal segmental glomerular sclerosis, FSGS. It's a very specific type. Flex Wheeler, again, this is not, we've known this. I actually knew the lead researcher at Columbia University, Leal Hurlitz, Dr. Leal Hurlitz. She is currently, last I knew, the chief renal pathologist at Cleveland Clinic. And she was involved. She just wanted to do stuff with steroids. We've worked together over years. She's a sweetheart. And I could tell you that steroids destroy the kidney on some men, different than others because of your fingerprint. Hypertension, too much steroids, and NSAIDs. So if you're hypertensive from steroids, brother, cut it down, dude. Shrink down. Don't be hypertensive. And then if you're on a low dose of test and you're doing the best you can, yes, telmisartan. And then if you have proteinuria, you have to be on a sodium glucose co-transporter because you have kidney disease now. Even if your estimated GFR is normal. I just had a little bit of an argument with a primary care doctor that I unfortunately proved him wrong, and it was very embarrassing for him because we have a patient, he's in his 50s, very wealthy man down here. He had diabetes, hypertension. He's in his 50s. He's a businessman. He lost weight. He's on testosterone. He comes to me. He has proteinuria. I said, sir, I checked your urine. You have proteinuria on the microalbumin creatinine ratio. You're not a diabetic anymore. You're hypertension. Everything's treated pretty well, but it's been going on for a year, and it's significant. It wasn't just a little bit. And I said, so you're doing okay. Your blood pressure, your ABCDs, you're on a little testosterone. In my opinion, you need to start Jardiance or Farxiga. And he got really irritated because he said, my doctor said you're wrong. I said, all right, let me talk to this guy. So we end up talking, and I think he unfortunately didn't even do any AI reading on this before he received the phone call, which is an embarrassment for him. Because I said, doctor, go to the standard nephrologic society and just put in what this guy has, and you'll see that he has chronic kidney disease now. He has proteinuria, and it's not going away. It's been out there for a couple of years. He's on a good medicine. He's losing weight on tirzepatide. He's on an ARB for the proteinuria, but we can do better. And if you put the stuff, AI is crazy for me, right? And it gives you all the reference support as of at the moment from the top experts in that world. You can argue that. And then it's like, okay, who's going to pay for it? So the guy, he agreed, it wasn't that bad, but I just thought, these doctors can't know it all. I don't know everything, but all I do is the heart and kidney. Okay, next question. One more question, I'm done. Man is great. Thank you. Man is great. First time here watching. Thank you so much for streaming this. I'm learning so much. Subscribing, been on Tier T for 2 months. Free T, 319, total 114. Whoa, it's okay, brother. So Terts, you get on there, dude, and you just get on to learn as much as you can. There's a lot in there, and just ask the testosteronologist. I'll answer your questions. And then let's get your A, B, C, D nailed. And maybe one more question. Okay. Pinning every day. Doctor said twice a week, sub-Q. I've been to alternative. Okay. I like the shallow. Look, Terts, here's the deal, dude. IM is how the esters of testosterone since the 1950s and 60s were developed because of the way they absorb through the intermuscular field, because of the blood distribution is different in a muscle versus subcutaneous. Subcutaneous compartment is fat. There's less blood supply. That's all it is. But so when you're injecting an oil ester into sub-Q department, it's funky things can happen. First of all, I don't like it because it can get kind of gnarly. I've done everything, and my patients have done everything. It's not a life and death thing. And testosterone enanthate, where's my little thing? Zyosted. Look at this, XYOSTED. Zyosted is a real testosterone product in America and around the world. And they have a patent not on testosterone enanthate, because that's generic. They have a patent on the delivery pen that is subcutaneous enanthate. Unbelievable. Now, it's $300 a month, though, guys. I mean, and insurance will never, because the insurance just argues, no, I can't, we can't. He's got cypionate and enanthate. He's got Gyme. They just won't go. So you could pay with coupons, I don't know, like $150, $200 a month. And the other problem with Zyosted is that it's fixed at 50 75 and 100 milligrams per milliliter, and then they only recommend it once a week. But if you want to pay your cash, you can do it. You can, like, I have guys that travel with it. It's really cool. Zyosted, check it out. And it's just super cool. You just pop it in, and I've used it. I got some samples, and I'm like, this is pretty cool. It's just easy. But I don't do it every week. I do it every 5 days, on enanthate or cypionate, right? Those are very, very similar esters. So, but guys, whenever I hear the sub-Q thing, I go, this is kind of a newbie. That's okay. And if you like sub-Q and it works for you, mostly sub-Q, the theory is that it evens out the distribution, because you're injecting it in a region of the body that has less blood supply. Imagine you're injecting your glute or your leg, and you're walking on your leg and it's squeezing. So in theory, or your delt, right? So remember the guys in the jail, they were rubbing it. You could rub it out, and it will go into the blood. It's like a sponge. It is true, because of the blood supply. But again, this is kind of esoteric stuff. So most men, put it in your muscle, just be done with it. Hopefully you don't get, find your sweet spot, deltoid. The last 10 years, I'm in the leg. I used to be in the deltoid. I've never done the glute because I can't get around to it because I'm so tight. And I don't like the ventral glute. If you're a ventral glute guy, on right here, boom, that's a nice area, especially with small injections. But I think delt, moving around, brilliant. But just keep it like you said, sir. I would keep it shallow intermuscular, and just move on, sir. And then take care of your ABCDs so you can just live like me forever, and hopefully with the grace of God, and have a great quality of life. Because I'm 62. All right, guys, that is it. I'm going to say goodnight. 2 hours. Guys are awesome. Get on Testosteronology. Mark, throw the stuff up here. We have a special offer today, 60% off your first month. Portal membership is only $9.99, guys, for everything for 1 month. The code is live999. So again, you want to go to testosteronology.com. You want to join up. We have more stuff. My guy Steve is the chief. You could see him on the portal for the executive team. Mark is back here hiding. We have more stuff. We're going to get more information for you guys. There's more doctors and nurses coming. The training is never going to stop. We're going to get prescriptions with telemedicine right to your house very soon. We're working on different companies that we're going to partner up with. We're going to make the best decision. So on the health portal, you're going to have one stop. You're going to have all the information from me and my testosteronologist. You're going to have labs with no doctor's prescription. You're going to have all the intel with all these videos to know exactly what to do. You could search and you get snippet videos we have almost 1,000 videos. I've been doing this 5 years, guys. Apart from social media, I've loaded this thing up with 5 years worth of every permutation and combination of hypertension, intermuscular, prostate, BPH, prostatitis, every single permutation combination you could possibly imagine of testosterone and steroid to protect men for the last, I don't know, I've been doing it 20 something years. 5 years we've been developing this baby. Okay. And then we're just there it is. Thank you so much, Mark. Check this baby out. The ABCDs health platform. You have to get on that. You have to do it yourself. We built this. We've developed this. It was not cheap. It was not easy. This is completely developed where you could put your own ABCDs in. If you guys are not lazy and you really, really want to do the work in here with me and my testosteronologist, you can get class 1. I do have some VIPs and billionaires, and a lot of them are kind of irritating to me. If they irritate me too much, I fire them because I don't need them. I need you. Okay. I need masses. Look at this right here. And I'm telling you that you can get all this information to stabilize and take care of your own health with all the biometric secrets, not bullshit from these guys on the internet that are selling you a bunch of hollow, non-scientific. You know where the real money is, guys? Real biotech. And if you don't like this, don't use it. But if you think you're going to starve yourself, if you think you're going to do fasting and you're going to use all these, and I have a supplement company opening up, really good, wholesome supplements that are real, vitamin D, K2, you'll see this. But if you look at the real truth, if you think those are all the doctors and nurses that are working for us, look at them all over the world, Chile, South Africa, Montreal, right? South Africa, Chile. Dr. Serrano's in here. There he was. There he is. There's so much information, guys. This is my dream to create it. It's open. It's functioning. We have a lot of people on this, and I want to get your feedback. I want this to be the first digital entity of the world to be truly a consortium, a place, a digital entity that you really can afford to get the absolute top of protective information, labs, and medicines. You do it yourself, your home clinic. But I don't want to be unethical. I'm not taking you away from a doctor. Most of you don't even have a goddamn doctor. And your blood pressure doesn't need to be checked in a doctor's office. It needs to be checked at home. And then you need to do something about it with diet, exercise, modification of behavior, and then, damn it, in the end, real agents that work. And then you need to be sustainable and feel great and have a great life. And this is the first digital platform in the world. Once we get the medicines on here directly delivered to your house, it's one-stop shopping. And I'm very proud about that, guys. But give us the feedback. Thank you so much, guys. All right, Mark, that's it. Woo! Next Wednesday, we're going to have Dr. Lazo, who's going to be presenting, talking about something about infectious disease.